So it sounds like we're pretty much annealed around, let me just see if I can summarize where we're at here. So smoldering myeloma still in the trial domain, but quite interesting, deep responses. We'll see how far we can take that, but wait for the trial results. Is everybody in agreement?
Yes.
Upfront therapy, both in the elderly and the younger patient, most of us are agreeing with a triplet approach, a proteasome inhibitor and an IMiD. We're on the cusp of adding a fourth drug for certainly young patients, maybe not so much for the elderly patient. And it sounds like all of us are using maintenance with an IMiD and layering on top of that a proteasome inhibitor for the higher risk patient. Is that a fair summary? A little bit of controversy about transplant. Let's just, we have a couple of minutes left on this, let's just talk about that. So if your patient enters, as Bob suggested, a MRD negative state, you still transplant them, Harry?
I do, for two reasons. Because our MRD tests are, as we know that the sensitivity level of the MRD tests keep changing. We have people who are MRD positive, MRD negative at 10 to the minus 4 can be MRD, or negative at 10 to the minus 4 can be positive at 10 to the minus 6. So, and there's data being presented again that makes a difference. So one, MRD testing is still not perfect. Second, we don't have sufficient follow-up. People who are MRD negative, even at the next-gen sequencing 10 to the minus 6 level, they do relapse. It's not that MRD does not equate with cure at this point. So I think for a young person to be denied the most effective platform that has got us here for a long time would be difficult for me to forego that. And second thing, people don't get younger and better with time. So if you're going to do a transplant ever, you better do it earlier.
Spoken like a true transplanter. Noopur?
So I have plenty of people in my practice who I will not transplant. And, you know, there are folks where I would suggest, where I'm worried about how they are going to relapse with renal disease, for example, where transplant may be off the table for those. Those are the ones I am going to encourage to get transplanted, including the high-risk ones. But there are certain standard risk ones. As long as I've collected those cells, I'm quite comfortable watching. The part where I do worry about is the older ones where I'm watching 65, 66, because as you pointed out, Hari, they're not getting any younger, and I'd rather get them transplanted and move on. So,
Cristina?
I think a little bit like Hari, I think it's still very important, and the goal, the MRD is our goal, and the number of patients achieving a deeper response is higher with transplant. So outside of a clinical trial where we're not testing, we know with transplant we achieve a deeper response, so I go there aggressively.
Bob, you sticking with your original hypothesis?
I am. Now, Hari does bring up a good point. When I mentioned MRD, I meant 10 to the minus 6. It may be interesting to save a sample of the bone marrow and peripheral blood on patients for future testing, like next-gen sequencing. And we're not denying the patient a transplant. We're certainly just giving them an option of transplant now versus transplant later. And we know from a number of studies that second-line transplant is just as effective, especially in a younger patient. I agree, if you've got somebody who's pushing 70, you probably don't want to wait. But the other benefits are they have a better quality of life without transplant, and they have a lower risk of second primary malignancies in many studies. So those are not things to be ignored.
Yeah, I completely agree. And for the community, the sad part is that only about 35% of patients who are below the age of 70 in the US actually get to a transplant center. And I think it's important that collection and holding at the very minimum is something that we should do in all our young patients.